Okay, let's get started. So first off, I'd like to welcome you all to the Sharon Brintnell Lectureship Award in Advancing Occupational Therapy, Recognizing Meaningful Living. So tonight, first off, I'm Shanif Ismail. I'm the chair of the Occupational Therapy Program. And to begin with, I just want to say welcome all of you, but also I'd like to welcome, we have guests virtually. We have our Calgary satellite program connected, as well as we have people virtually joining us globally. So we have individuals from Europe, Indonesia, you name it, they're coming on to this. So we're really happy to have this event on this evening. So to begin with, I would like to specifically acknowledge the Alberta College of Occupational Therapists for being major contributors to this award. Oh, louder, sorry, I will bring it up. So I'd like to specifically acknowledge the Alberta College of Occupational Therapists for their significant contribution to this award. But before we begin, I'd like to introduce Dr. Tammy Hopper, the Dean of our faculty, to provide greetings and offer a land acknowledgement.
Thank you very much, Shanif, and welcome everyone. It's so great to see you all here in person, and welcome to everyone online as well. I see the numbers ticking up among the attendees, so we have a great audience tonight. I would like to start and begin in a good way by acknowledging that here on the North Campus of the University of Alberta, we're located on Treaty 6 territory. And Treaty 6 territory is home to diverse Indigenous peoples since time immemorial, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, and Ojibwe, Saulteaux, Anishinaabe nations, and Inuit nations as well. And some of you may or may not know that Edmonton has the largest population of Inuit people south of the Northwest Territories. So we have a large proportion of Inuit individuals in our community. And as you also may know, June is National Indigenous History Month. And as part of our celebrating and acknowledging the histories, languages, and cultures of diverse Indigenous peoples who have lived on these lands since time immemorial, it's also a time for us to individually and collectively make commitments to reconciliation with Indigenous peoples. And these can be anything from recognizing and addressing Indigenous specific racism in healthcare in practice, to learning more about the history of Indigenous peoples on this land through one of the educational opportunities we have here at the University of Alberta, the Indigenous Canada MOOC, which is available online. If you type in Indigenous Canada, you'll be able to find it. So having said all of that, and beginning in a good way, I also want to come back to the reason we are here tonight. So we are fortunate to welcome two speakers who understand and appreciate the influence of history and the work we do, specifically in the realm of rehabilitation. Katie Lewis and Dr. Elizabeth Townsend, recipients of the E. Sharon Brintnell Lectureship Award in Advancing Occupational Therapy. They will be sharing with us tonight their work on occupational therapy in Canada during the period from 1950 to 1985. And I'm very much looking forward to their presentations. It really is a privilege for me as Dean to be here for the return of this event. It has been a few years since the last Sharon Brintnell lecture, and as many of you will probably recall, this lecture is in honor of Professor Sharon Brintnell, who joined the Occupational Therapy Department in 1971 and was a key person and a leader who contributed to its growth and, and advancement all the way up to her retirement in 2018 and through to today. Thank you to anyone here who has supported this lectureship through your donations in Sharon Brintnell's name. Your generosity is the foundation upon which we continue to advance the transformative influence that Sharon has had on occupational therapy and indeed all of the rehabilitation professions. It's great to see you again, Sharon. So thank you to our guest speakers, Katie Lewis and Dr. Elizabeth Townsend. Thanks to all of you for joining us and all of you online as well. And now I'll hand things back to Dr. Ismail. Please enjoy tonight's special lectures.
All right, thank you, Tammy. So I'm truly honored. I'm going to hold it up. Yes, I'm truly honored to speak to you today about the significance of this lecture and why it was established. The most difficult part of this evening for me is that I've been only given 3 minutes to introduce the lectureship and share a bit about Sharon, which is very difficult. The Sharon Brintnell Lectureship Award was established in 2018 to honor a true leader in our field. Sharon Brintnell has had an illustrious 54-year career advancing, developing, and advocating for our profession globally. Sharon's international accomplishments are profound. She played a critical role in establishing OT programs in Indonesia and Kuwait. In Indonesia, her visionary leadership and collaboration with SIDA and the World Bank led to the establishment of the profession in the country. Sharon's efforts have earned her the endearing title of Mother of Occupational Therapy in Indonesia. Today, the profession is well established and is seen as an important component of the Indonesian healthcare system. Just this year, the Workforce Ministry announced they plan to support the creation of 8 new OT programs, where Sharon is going to be involved in some of that. During her tenure at the University of Alberta, Sharon played a key role in advancing our program. In the 1980s, she guided the program's accreditation and developed an innovative curriculum based on a theoretical model. This approach is now standard component of any OT curriculum. Even back in the 80s, there was a significant shortage of OTs. So to meet the critical provincial shortage, Sharon negotiated funding and designed and led an accelerated program, graduating an additional 120 occupational therapists in just 4 years. As a side note, I was one of those students. Sharon also established the Occupational Performance and Analysis Unit using a nonprofit community rehabilitation model demonstrating occupational therapy's vital role in medical legal assessments and support for veterans and First Nation communities. On top of these accomplishments, Sharon has served as a president of the Canadian Association of Occupational Therapists and the World Federation of Occupational Therapists. Her leadership in these roles has significantly influenced the profession nationally and internationally. On a personal note, Sharon hired me as a sessional instructor in 1990. Her mentorship and guidance has been pivotal in shaping my career. Even after retirement, she continues to contribute to our department and to international projects. The purpose of this lectureship is to engage students, alumni, faculty, and the broader community, and to recognize individuals who have made significant contributions to advancing occupational therapy. And now it is my great honor to invite Sharon Brintnell to share a few words and introduce our speakers. Please join me in welcoming Sharon.
I fondly call all of the people that I have been involved with personally, all my chickens. And Shannon is one of my prized chickens. Rooster, maybe. It's so wonderful to see you all. For a while there, we thought we'd be playing to an empty house, but you always come through in the end, so welcome. And to all of you, you've heard enough about me. It's my pleasure to introduce our guests, and I'll just check on my notes, because if I ad lib, I'm sure I'll leave out some significant things. It is my pleasure to welcome, where are my guests? Oh, sorry, yes, you'll have to remind me, our speakers, Katie Lewis and Dr. Elizabeth Townsend. Both of them are part of a dynamic continuum of inspiring and inquiring occupational therapists, exploring the enigma of occupational therapy and how occupation Meaningful activity, for all of you that need a translation, shapes our daily lives, thus helping to lift the mystique of how ordinary, everyday actions are therapeutic. Katie Lewis, a graduate of the University of Toronto, and occupational, is a clinician and a PhD candidate. Clinically, she works in the neonatal follow-up clinic at McMaster Children's Hospital and privately in the community. Her clinical focus includes the preterm phenotypes and aquatic applications of occupational therapy. You can ask her for a translation. Katie's doctoral research, and why we're here today, uses archival sources from across the country and oral history interviews. Her work explores how occupational therapy developed from an educational and professional perspective, considering factors such as gender, healthcare hierarchies, and consumer needs. Katie is a recent acquaintance, but much valued as someone interested in all my many boxes of hysterical stuff. I'm in the process of sending them to Katie. Dr. Elizabeth Townsend, my son clapping because my office is overloaded at home. Dr. Elizabeth Townsend, Liz, and I have a long and convoluted relationship that began in the 1970s. And on and off, we have had many wonderful experiences. A graduate of the occupational therapy program at U of T, POTS, which I share with her. That stands for Physical and Occupational Therapy Joint Credentials. And we've worked on many national occupational therapy initiatives. Liz is a prolific and renowned occupational science and occupational therapy scholar and educator. She's an accomplished author and co-author of numerous textbooks and articles. Her research and formulation of constructs relating to social structures and their influence on occupational engagement transcends the profession, serving to inform other disciplines of social injustices in access to doing and advocating strongly for change. Kate's historical focus on the benchmarks and their meaning is a critical era for developing rehabilitation services, particularly occupational therapy. Also sparked color commentary from those who lived the experience. Her research provides a historical context and hopes to illuminate factors that contribute to shaping today's rehabilitation and in particular occupational therapy services. In many quarters, the power of occupational therapy, even in the face of adversity, often a medical diagnosis, to promote positive health and well-being is still a well-kept secret. Let it be known that harnessing the simplicity of engagement in common everyday activities can profoundly impact our quality of life. Katie and Liz, welcome. The dais is yours.
Hello, everyone. I cannot thank all the people who were involved in my invitation enough for being able to come here. First of all, I'll give you just a quick comment from the personal side. I have lived in Edmonton years ago. I had an uncle who farmed east of Wainwright, and I used to spend my summers in Alberta. And my father was raised in Manitoba and had uncles in Winnipeg. So I really have a great connection to coming to this part of the world, and it's wonderful to come back. the other part of my appreciation for being here is to present with Katie. We met about a year ago when she was doing historical research, and I jumped at the chance to talk about rehabilitation during the years. I didn't start in 1950. I do have to tell you, I'm not quite that old, but a lot of the time that she has been researching occupational therapy, I've lived it. And so we've had a great time putting the presentation together. Katie will now speak to the slides, and we've left some time for discussion. Over to you.
All right. Okay. I wonder if I can pin this at a good, oh, that's upside down. How are we feeling? C'est bon? Okay. We've got a few slides. Here we are. All right. So thank you very much for those introductions, and welcome to If It Ain't Broke, Why Rehabilitate It? Canadian Occupational Therapy in the Rehabilitation Era, 1950 to 85. So I would like to take a moment to recognize that coming from McMaster, I am on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the dish with one spoon wampum belt. That wampum uses the symbolism of a dish to represent the territory and one spoon to represent that people are to share the resources of the land and take only what they need. Liz, coming from Dalhousie, we acknowledge that Dalhousie is on the ancestral and unceded territories of the Mi'kmaq people, and we want to pay respect to the Indigenous knowledges held by the Mi'kmaq people and to the wisdom of their elders, past and present. Doing history work, I think it's especially important to speak to this land acknowledgement and to recognize that there is a long history of historians either overshadowing, outright ignoring, or trying to paint over Indigenous history. And we want to be cognizant of that. So moving into my presentation, the rehabilitation era, friend or foe. If we are familiar with Brintnell's research, you might recognize this title. But the rehabilitation era is a time period in Canadian occupational therapy that spans from the 1950s to about the 1980s. This is a socially understood era, and so there's kind of soft end and start times there. And what the rehabilitation era does was it really focused on this narrow remedial physical rehabilitation. And that has led to a lot of discussion in modern day about if this was just straying from our holistic roots, if we made a series of missteps over the course of this period, we as occupational therapists. But on the flip side of that, we have this huge demand for occupational therapy. At the end of World War II, the Canadian government really wanted to fund healthcare. They were looking to make it quite different from the experience of World War I. And so there's lots of money and there's lots of availability to increase OT, and which ended up happening. So we have the growth of the profession, we have the expansion of the education system to supply these occupational therapists, and there's a lot of roots that do come up into today as well. So it's this contested era that we are hoping to understand more fully moving forward. So why do we care about history? There's different interpretations of our history today, and those interpretations, as well as the actual history itself, both inform what we're looking at today. So how we are reflecting on the past, as well as how we are living the past today, both inform the practice of occupational therapy today. So this period has really set the stage for modern occupational therapy. Even me saying that right now, some people would definitely dispute it. But where we are practicing and where we see occupational therapy across Canada certainly has roots in the rehabilitation era. We also need to learn from this history if we have a hope of making a new coherent identity that is easily digestible for a lot of different professions outside of ourselves. So as Sharon mentioned, we are this secret that once people learn about, seem to really appreciate, but the lay citizen does not seem to understand that consistently. And so looking at what we've done before and understanding that context and why we made those decisions moving forward is very important. So moving into my research, I did a synthesis of archival and oral history research. So for history methods, typically the data collection, the primary research comes from primary sources, which are documents that were written at the time that you are looking at. So I went all over Canada. I focused in Ontario, Quebec, Alberta, and British Columbia. That was where the concentration of occupational therapists were and the education programs during that time period, and looked at a variety of different sources, you can see above me. What's interesting about the archives is what was decided to be kept, as well as what was decided not to be kept. So if you're going into archives, often what you find is occupational therapy is thrown into the occupational health and safety portion. Not really what we do 99% of the time, but alas, some archivists felt that was important. Or we're grouped into allied health or a similar type of umbrella where the kind of nitty-gritty details are not included or kept in the record at all. It's not limited to hospital systems. The similar thing is happening in academia. If you happen to get lucky, you'll find some course-related materials, not necessarily. University of Alberta. It turned out it was just Sharon who had all of those materials. But there's other universities that do not have a lot of actual occupational therapy documents. The other thing is that often there is just no mention of occupational therapy whatsoever, even when we know that there was occupational therapy present. So this has been completely disregarded and not saved. And so due to all of these holes in the archival research, it's not telling a complete history, I decided to complete oral history interviews. So I completed 39 oral history interviews with participants who had either practiced as an occupational therapist or graduated from an OT program before 1985 in Canada. These were 2-hour semi-structured interviews, and then I thematically analyzed their responses. And so I did these oral interviews to get a better sense of the actual history, because there wasn't a lot of it written down, and also to get a sense of the lived experience. I know from my own experience as an occupational therapist, if somebody was to go dig up my job description, it wouldn't really match up with what I do day to day. That would not be an accurate representation of me. I think that is certainly not a me-only occupational therapy experience. And so having these interviews really fleshed out the history. So this is going to structure the rest of our talk today. So in my dissertation, I have analytical lenses. So this is how I'm looking at both the archival research and the oral history. So I have citizenship, professionalization, and gender. I'll be speaking to all of these in a bit. So looking through these lenses, next we're considering the historical context. So this is what Canada looked like, or the smaller, provincial territory, etc., looked at this time, the funding models, the legislation, the kind of hard details that just existed. And then on top of that, nested within, is the scope of practice. So this is the actual occupational therapy role. They're all nested within each other. Okay, so to start, professionalization theory, I used Andrew Abbott and Elliot Friedson, and they talk about negotiations of professional boundaries and expertise through consumerism and managerialism. So what this means is that often professional expertise is thought of something that starts within the individual or the profession and emulates outward. You are telling what your professional expertise is. But that is an incomplete picture, because we're not thinking about the consumers and how they perceive your expertise, as well as the managers and how they're directing your expertise. So it's more of a dance between the three parties in negotiating what is your role. So who do I go to consume whatever I need, right? If I've broken my arm, who do I see? Who is the expert as a consumer? And then on top, having a manager direct what is your job description, where will you fit in this hospital or community, what have you. So it's this dance. Andrew Abbott also brings up system disturbances, and these are major events that provide an opportunity for a renegotiation of your boundary of expertise. So there was a big one in between 1950 and 1985, which was the transition to public health care. This provided a massive opportunity for boundary renegotiation. You could guess how OT came out on that, but we'll get to that. So those kinds of things is how we're thinking about the professional identity of occupational therapists as we move forward. Citizenship theory is discussing what it means to be a citizen in a social understanding. So at the start of the rehabilitation era, we had a productive understanding of citizenship. So that is, you needed to be contributing to the economy in some kind of way to be considered a citizen. There is layers to that, of course, with gender and with race and that kind of thing. But socially, you're a citizen if you're producing. So in turn, what are the goals of health? To return somebody or get somebody to be producing in the economy. That is a citizen. That is what's shaping the goals of healthcare. That is what's shaping the goals of occupational therapy. By the end of this period, we're turning into a more of a social understanding of citizenship. So that is saying that there is inherent worth in all individuals. And that in turn shapes healthcare goals, shapes occupational therapy goals. That's where we start to see more of looking for rehab for meaning in life and just meaningful activities and not simply return to work. And finally, gender theory. Occupational therapy has been heavily dominated by women, really since the start of time, continues to be. And it is important to consider how feminine expectations in the workplace and home and academia all factored in to the occupational therapy experience. So this is broadly how I've structured my dissertation, and these go thematically as well as chronologically. So legislative changes had the biggest impact early in the period. They do continue throughout, but biggest impact, then we're going into citizenship considerations, education, professionalization, and gender. So as I've mentioned before, there was this notable shift from private into public healthcare funding model. And with this, there was an incredible amount of investigations into how should we be spending this new money that has just been infiltrated into the Canadian healthcare system. There was another notable shift in the late 70s, early 80s, where there was downsizing. So this money has largely run out. It came from World War II by and large, and we've run out in the 70s. Really what that means for occupational therapy is there used to be occupational therapy departments just about everywhere in hospitals. You were managed by an occupational therapist. You had a discrete group. You were all together. You would point to the OT department. With downsizing, that's shifted to a program-based supervision model, which means you were less likely to have an occupational therapist supervise you. And so now it's just in your group. So I work in a neonatal follow-up clinic. I'm managed by a nurse. I'm not part of an OT department anymore. So that shift reduces the visibility of occupational therapists. There's also a tension between provincial and territorial or federal funding models. So there was differences across the country. When we switched into public healthcare funding, there was a cost splitting approach. So the province would share the money with the federal government, or the costs rather. And with this, there was differences across the provinces. What's important to note here is that the Canadian Association of Occupational Therapists, CAOT, is a federal program. And so they are trying to navigate provincially dedicated money and advocate on a federal level while most changes are happening at the provincial level. So there's these tensions there on how can CAOT navigate and advocate appropriately when most of the money is being spent differently across Canada. There's also this conceptualization of citizenship shaping legislation. So as I talked about before, what constitutes a citizen then constitutes legislation in part, which then constitutes healthcare goals. So if we move into citizenship, there is this change between productive and social citizenship, but there's also this shift in who is responsible for health. So at the start of the 1950s, early 1960s, the responsibility for maintaining your health was on the individual. So there was not an expectation that you would go into a hospital, you would get healed or fixed, and you'd come out no problem. That is a novel understanding. That shifts with the increases in medical science, medical technology, vaccines, the like. All of a sudden, there's this expectation that if I go into the hospital is going to cure me, and I'm going to come out of the hospital no problem. If that is the social expectation of a hospital, that cascades down into members of the hospital. So the expectation is you meet an OT, OT is going to fix you, rehab is going to fix you, you're going to come out of that the same or able to produce. The next is the increases in self-representation. So individuals with disabilities themselves started to represent themselves in advocacy groups in the 1950s, 1960s or so. This is a big shift from benefactors representing them. And in that, there's a stronger voice in what people actually wanted. So in the 50s and 60s, I think it's important to remember that many individuals with disabilities did in fact want to be able to be working. And so they were strongly advocating for occupational therapy to be doing this remedial type of work to get them into work. There, especially in cases of paraplegia or the like, where some physical adaptations, you're good to go kind of thing. And at the same time, occupational therapy is starting to represent themselves. So we have the first female occupational therapist running CAOT in 1966, and that is a big shift from having a male physician kind of look after us, for lack of a better term. Finally, there's also the tension between the environmental model and the medical model for disability. So one of the common criticisms today is that the rehabilitation era was where OTs did a medical model approach, and it was just a shame because the medical model is terrible. Yeah, we all know the medical model has its severe limitations. However, since day one, occupational therapy has had an environmental model. It wasn't explicitly named as such much before the 1980s, but it's coming up consistently. If you're looking at a patient or a client as an occupational therapist, you are considering their environment and how that is facilitating that. That is in fundamental odds with the medical model, right? The medical model says that disability lies within the individual. So if you look at the environment, you are no longer only blaming the individual for their disability. So all this time, occupational therapy has consistently been operating in opposition with the medical model. There have been elements of the medical model that have been in job descriptions or in hospitals or this kind of thing, but it has not been a consistent approach of we're just medical model, blinders on, we're gonna fix you, get you out of here. This leads us into education programs. So the education programs in Canada exploded over the rehabilitation era. We started with one at U of T, and by the end, there was 11 across Canada, with Dalhousie being the most recent in '83. There was also the case of the special program in Kingston and the Mohawk College experience, or problem, as it's often referred to. So early programs, including at McGill and at U of T, included the physical and occupational therapy program, as Sharon mentioned earlier, this combined program that literally everyone hated, except for the people who decided to institute it. I have a lot of quotes about how dumb an idea that was. Archie Cooper shouted at me in the interview, "That was stupid and you can quote me." So here I am quoting Archie Cooper. Most of the graduates practiced as physiotherapists. It was heavily physiotherapy oriented. It aligned better with the medical model and the physicians running the program, unlike occupational therapy. On the flip side, though, there were many occupational therapists, this one included, who only discovered occupational therapy after showing up to their physiotherapy diploma program and realizing, oh, we're getting this other one too, and then practicing and turning out to enjoy it. So it was a double-edged coin, but certainly not appropriate. The special program in Kingston really highlights the tensions between occupational therapists and advocating for their own value versus the government and the perceived value. So that managerialism kind of component here. So this was a program run by CAOT for about 10 years. All of those 10 years, they were relentlessly campaigning the provincial government, the federal government, Queens, somebody to fund this program instead of them funding it themselves. They did not have success in the initial to build up for it, so they just started funding it. And then eventually the federal government agreed and gave them some money, and it jumped over to Queens. Interestingly, during this time period, if you go into the Queen's archives, nobody is even mentioning that occupational therapy is pounding on their door every day, hoping to join their course. So it's this interesting dichotomy between CAOT saying, we need OTs, there's a shortage in the country, that we're valued, we need to be producing more. Queens, the federal government saying, who are those guys? What are they talking about? For the better part of a decade. The Mohawk College program is another interesting component where the federal government felt and the provincial government felt it was appropriate for occupational therapy to be practiced at the college level and greenlit a pilot program originating at Mohawk College. CAOT fought this tooth and nail, saying it was fundamentally inappropriate to have occupational therapy at the college level. This was a hard line to toe at the beginning of that argument because they were still producing diploma programs at the university level. And so certain OTs were graduating with a diploma at the same time they were saying absolutely not to the college level diploma. Ultimately, the government ignored CAOT, greenlit the program began. CAOT did put an end to this by refusing to let graduates of the Mohawk College program register with CAOT. Eventually, they move over to McMaster. That is why we have the McMaster program today. But it's an interesting case study in this perceived value of our own worth and advocating that we are worth more than a college level diploma, and external bodies being like, not so sure that's compelling, I'm going to carry ahead anyway. This really plays into the fears of becoming a technician. You see that more in American occupational therapy history. So right near us, they are on a bit more of a technician or assistant level track. And that was certainly not wanting to be the case in Canada. There's also the question of where is the science? So if occupational therapists are sitting here saying we must be at the university level, it is critical we get a baccalaureate degree. Universities responded with, where is your research? Where is your science? Where is your evidence-based practice to justify you at this university level? Which was a back and forth that happened at just about every school across Canada and often led with academia or the faculty insisting on more research being done. The trick is that at this time, there was no Masters of Occupational Therapy earlier in this period, nor PhD. So there's this external pressure to have more research, to have professors being educated at a master's or a doctoral level. And within the profession itself, there is no opportunity to do so. So what happens is that occupational therapy professors go and get their additional higher level learning in a different faculty, in a different area, tied, but not exactly occupational therapy. This has a cascading impact in that it is shaping how schools are being taught. So if you go and get a master's in psychology or education or what have you, that's coloring how you're going to be teaching occupational therapy. So there becomes this diversity in educational experience across Canada, which then translates into a diversity of practice as well. So we're seeping into more areas and different areas. We all have these different educational experiences, different priorities, some strengths in different areas, really expanding the scope of practice, which has strengths and weaknesses in that it becomes harder to simply say, what is an occupational therapist? What do you do? What are your guiding principles? What are your core tenets? We're all being molded by different professions. Next, we have professionalization. So in this time period, there's huge evolution and contestation of the scope of practice. So due to the flexible nature of expertise and the increased opportunities available that the public sector brought, there was an increased number of occupational therapists having expertise in a variety of different settings, having quite a fluid skill set. This has pros and cons, as there was many opportunities that we're seeing OTs in brand new settings and starting OT departments or OT areas. The flip side of that is it becomes harder and harder to understand what an OT does. So you meet an OT in a children's hospital somewhere, they do something, you meet an OT in the community, they do something that's completely different. They're like, wait a minute, then there's one in mental health, there's one in return to work. It's getting more and more confusing for people to succinctly understand what is an occupational therapist. That's very different from the 1950s, where if you meet one, most of them are doing a pretty similar role. We also have the concept of who is in charge of occupational therapists. So as I mentioned, with the shift and downsizing, we're getting fewer and fewer occupational therapists being in charge. So external professions are dictating the scope of practice in the sense that they are dictating the job. So you are going to practice within the job that has been outlined by a physician or by a nurse or by a community agency, what have you. This all really struggles or has a culminating impact on the perception of expertise. So what are OTs the people of? If you go and poll people today, you'd get very different answers. If you poll new grads today, I think you'd get very different answers. Same thing would be happening in the 1980s, 1985, not so much in 1950. Finally, we have the consideration of gender. So there's the context of the feminist movement that's underpinning this time period. I also want to talk about colonial considerations. And so it is important that a gendered analysis is critical to understanding colonial power and therefore vital in considering anti-colonial Indigenous struggles. So there's these dominant liberal European feminist concepts and that have played out throughout this time period and are relevant when we're talking about gender. There's other considerations for professional women. So women in academic settings, in my oral history interviews, many of them talk about being talked over, having difficulties sitting at the table that is often otherwise filled with men. There's some differences now as I am here at U of A, but that is a consistent theme. Same in healthcare, often dominated by male physicians. And there are the priorities between work and family and children. So when I was talking in my oral history interviews, a lot of the women will talk about their professional trajectories relative to where their husbands got jobs. So it's like, oh, what brought you to Yellowknife? Oh, my husband. And then I went here, then I went here. So the women who were able to go up the ladder were either unmarried women or women who happen to have husbands that stayed put, which is difficult when you're trying to build a professional identity. So if I'm talking about many issues that are ringing true today and seem to be hammering on similar points, it leads to the pretty obvious question, in my opinion, of is Canadian occupational therapy stuck? So on one hand, we have funding that we can't seem to develop beyond pilot programs. There is notable exceptions to this rule, but those are heavily personality dependent. So we have these instances of really strong personalities going out and getting immense amount of funding, doing an excellent job with a pilot program, and then it not being transitioned into another OT, or it's staying put, or it's transitioned to a nurse, or it's gone out of business, that kind of thing. It seems to be very personality dependent. We have this palpable frustration in defining ourselves as a relatable collective, and that continues to grow over the time period. And we have significant challenges replicating the change we make on a one-to-one level. So scaling that up seems to be a real sticking point for occupational therapy. On the other end, we have this incredible diversity of practice, which leads to this fluid skill sets and makes us have an impact in a really wide variety of settings. The changes we have made in the past have led to meaningful groundwork that we could scale up if we were able to kind of harness that groundwork appropriately. And we are consistently quite valued by clients and by colleagues. There is evidence to say that we do make a difference. That is known. Again, it seems to be more about the person than the profession and being able to kind of shift that. So what are we learning from this history? I've listed quite a few up here. So the previous solutions have tended to be impactful, but on smaller levels or on shorter timeframes. We've tended to pay insufficient attention to funding and management when we're looking for change. We have had significant difficulty in trying to form a professional identity. We do have these core tenets that are common across practice settings, but we have a lot of challenge identifying those core settings and naming them consistently. So these dilute down to these three big ones for me, which is identity and being a digestible, understandable identity to the lay public, agency in demonstrating our own value and making our own decisions and where we practice and what we do, and then value in terms of the one-on-one value, which we've got, and scaling that up and extrapolating it into a more population-based value. So I've mapped history onto the CMOP-E. So if you're not an occupational therapist, this probably looks like a bunch of random shapes to you, which is valid. So this is the actual CMOP-E. You might have met somebody who had a role in this. And we use, so the CMOP-E, sorry, it stands for the Canadian Model of Occupational Therapist and Engagement. So there's the person, the environment, and the occupation. OTs use this model to look at how we can help and change, facilitate meaningful goals. So we consider the interplay between all three of these levels when we're looking at the OT domain to create change. So this is the real CMOP-E for context. And this is my historical CMOP-E. So I'm looking to OT ourselves with this history. So I've remapped the environment to be the historical environment, including external forces, the perception of us, the value, both internal and external, and the scale of impact. The profession in terms of our expansion, our identity, and our frequently insular focus. The person, which is occupational therapists themselves in their frustration, their personality, and their agency, and then the core tenets. And so as with the CMOP-E, if we look in the overlapping three rectangles there, we have an opportunity for change in drawing upon this history and moving forward with a more coherent and digestible identity. And those are my thoughts.
I thought as one sort of personal illustration that Katie has heard me talk about, I'm most known for working in the Atlantic region and had the opportunity to work in Prince Edward Island for years. And we, talking about funding and so forth, underlying everything she says, I think is this question of what power do we exert? Where is our power in the system? Who understands what power we can generate as things go on? And in the Prince Edward Island situation, we decided to put a committee together to look at change. At the time, I think we had something like 8 occupational therapists, and our strategic model said in a few years we're going to have 36. And they looked at us askance, but we did apply to the federal government for funding to start a community program at the time when community was moving forward, and Manitoba had a wonderful arthritis community program, and there were all sorts of initiatives. So we got funding for three occupational therapists and a coordinator who started in the social services setting. So it was social services funding, not medical funding. It was a 3-year grant. And when the grant finished, we had all sorts of evidence. We'd collected data of personal stories, but also data of how many people had been seen through social services, entirely different than the community practice, because we were working with, single parents and kids who were on welfare and needed some support for going to school with a disability and so forth. Anyways, the moral of this story is that the history that Katie recounts through these slides seems to speak very much to the example of, yes, everybody in government in Prince Edward Island wanted this to continue, and yes, they were going to come up with funding for the position. And then one doctor spoke up from health and said, oh, we should have that in health, and it was moved to health. It never recovered. The role changed. There wasn't a community system for the occupational therapists. And just a personal example that Katie has heard, but I share that with you because probably you all have examples where our power wasn't really enough to move these initiatives forward. So over to you guys for comments and questions. Oh my heavens. And Sharon raises the question of the changing focus of the guidelines. One of the things that Sharon and I worked on was, for some of you who have been around for a while, the yellow books. And this CMOP-E is evolved from an earlier version of it, but we had opportunities. Maybe you want to say something, Sharon, when it comes to no, it's okay, because we're into the question and comment section of the thing, and I think it would be useful for Sharon to share this example.
Well, as those of you that know me well, I can be quite forceful in my directions. And in this case, the federal government funded us for guidelines for clinical practice, just like our physical therapists had. And when I was president in 79, when I wrote the letter requesting that opportunity, and it came later after, I insisted with CAOT I be on the committee, having got the initiative going. But the key was when we came to the first meeting with the representation from across the country, one from the East Coast, one from Quebec, one from Central Ontario, one from the West, and one from BC. All federal government committees had that. And we had a medical doctor, a physiatrist, the bane of our existence. They didn't come around to 1945 after the war, but somehow they got control of the girls. And that is in writing when a learned physiatrist in the Canadian Medical Journal wrote about the girls, whereupon I wrote to the editor about the girls. But the point was they wanted clinical guidelines. And at that time, as Katie said, we were upgrading, and I was doing my work in family studies, sociology. And I said, we're not doing client guidelines. We're bigger than the clinical guidelines. We're going to do client-centered, because the other thing I was studying was psychotherapies and the humanities and Rogers and person-centered, client-centered therapies. So that was a primary example of how we brought from the areas. But that moment, we won the battle, and we also introduced spirituality into the paradigm, which was, oh my God, because there is a badge at the beginning of occupational therapy in 1919, mind, body, and spirit. And it really is quite powerful And it disappeared in the 40s because the badge had a picture of the rising sun and a hand with a map. And it looked too much like the Japanese and the communist symbols of the time. So they threw it out. It was to come back. So we were powerful then in, we were powerful then in influencing that committee and the yellow books, which led on to many other developments. And it was probably one of our biggest impact moments as a profession across the country, because every therapist took the yellow books. And I had one administrator demonstrate it. I don't want to see these yellow books in my face anymore. So, power.
There have been some instances of it. I guess the question is, where else can it come forward? Who else would like to comment? Or there we go. Shadow's got the.
I have a question from Calgary. Were there any positives that came out of legislative changes when shifted to department managed by non-OTs?
Oh. I suppose it depends on your perspective on that one. There's pros and cons to department versus program-based structuring. So the program-based argument is that you are collaborating more strongly within your program. It promotes interprofessional collaboration more strongly, and you have a clear sense of direction because your boss knows exactly what you're doing in your program. So the pros of that would have been increased interprofessional collaboration, and perhaps stronger programs. I think what came out of that was strengths for nurses. There's a lot of nurses that have held supervising positions since then. So that has been a pro for them. Not to say that there are no OTs and that it's banning OTs. So part of it is on us. We need to be reflecting ourselves why we're not often program managers. But that's most often. So mixed bag. It was not a complete wash. Absolutely. It just limited the visibility of occupational therapy within a hospital as an entity, which is compounding the struggle when you are already not particularly well known.
Having lived through that, as many of you maybe in the audience have, we were not good at speaking up and saying, I'd like to be the leader of this team. And maybe it was because we had a bunch of kids at home, or we were about to move, or something else, going back to school, lots of reasons. But in my experience, it was rare for the OTs to end up as program leaders. So, and as Katie says, that's on us. That's a great question. I'd love to hear from any of the people who lived through part of that era anyways. Maybe you have your own examples that either support Katie's historical analysis or bring something new to it. Ah, there we have her. Yeah. Yeah.
Wow. My name's Lorian Kennedy, and I was Lorian Demetrician at the time, but when I left the University Hospital in 1971 to work for Goodwill, I didn't know if I was still going to be seen as an OT by the rest of my colleagues. But I thought, well, I think the education I have suits me to this role, so I'm going to do it anyway. And luckily, my colleagues did accept me as an occupational therapist in that role. It was called a work evaluator. We didn't have an OT, we had a work evaluator. But you know, nobody else was out in the community. All the OTs were working in hospitals. If you were an OT, of course, you worked in a hospital. That's where they were. So that was a really big change.
You've done an amazing job, and it's a wonderful example of continuing on and finding a way through. I guess I wanted to say as well that Sharon's signaling me the Mohawk, you know, putting Mohawk aside was certainly a point of power. And The other thing that I wanted to add to this is the issue of legislation, because in there, with the professionalization of our, the provincial control of occupational therapy, I personally found situations where what I was doing in the community didn't count as licensing hours. So if you want to go back and look at the legislation for occupational therapy, wherever you are, make sure that what counts is as broad as you can make it, as broad as the examples that you give of people who worked outside the hospital system. Too often, you have to prove clinical hours with an individual client. Where's the community practice? Where's the legal practice? Where's all that sort of stuff? So I'm sure there are stories of people who manage to stay licensed, but there are also lots of people who say, well, I can't come up with that. I don't need to be called an occupational therapist in what I'm doing, and I'll be called a program manager. And although their job description, their application for the job might have required some kind of professional background, it could just as easily be, say, social work. And so when they leave, an OT might not necessarily follow. But do take a look at legislation. It's a really powerful thing for either supporting us to move forward or putting the brakes on. And I have personally experienced both sides of it. Yeah.
Katie, thank you for your presentation. It's such an honor for me to see Dr. Townsend in person. I'm curious to know what kind of measurements have been taken during the history of occupational therapy to get international OTs more involved in your community, because I am an international occupational therapist, and I'm curious to know what kind of measurements have been taken, and do we have a diverse community in occupational therapy right now? And what is your perspective about it?
I would say we don't have a diverse community in occupational therapy right now, although I could just be biased with my experience. Certainly there was a lot of access for certain internationally trained occupational therapists to come to Canada through until the early 80s for sure. It was an open access. A lot came from England, especially, and that had really limited restrictions on it at all. Eventually, there was an internationally trained exam that applicants had to take. And since then, I believe it's gotten much harder, although I'm not as familiar with that process. But for a time, there was a certain type of occupational therapist that would be welcomed. There was also not a ton of diversity of OT programs internationally. But the international piece is very interesting and I think warrants its own examination if we were to compare ourselves, like Canadian with Australian occupational therapy, Brazilian occupational therapy. There's a lot of interesting conclusions one can draw from what year you started. And I think that has a lot of impact. I think Australia is often way ahead of us, and that is a factor because they started later and they're better understood now today. So there's a wide range of answers, I suppose, to your question.
Yes, and just to illustrate, the Brazilians, since you mentioned them, have published a book on social occupational therapy. If you haven't already seen it, it's well worth looking at because they couldn't get funding in health sufficient to grow occupational therapy, although there are some in the health system. So they've gotten funding in social services and NGOs, all kinds of other sources of funding, and they've actually sort of been able to advance that way and really grow the profession in Brazil, and Argentina has done a lot of the same sort of things. So
Thank you.
it's a great question though about the international, because of course we have all sorts of people coming to Canada and some have done occupational therapy elsewhere. Sharon has just asked the question. I can repeat it. Speaking to the influence of occupational science. Oh, that's really interesting because I discovered occupational science in the 90s, and I'd have to say it opened a window, a door, whatever, for me, because suddenly I began to think about the occupation in occupational therapy. And if you've looked at any of the occupational science materials, there was a consideration, and some of you will know the name Dr. Anne Wilcock, as having done a lot of work in Australia, but at the same time, there was occupational science developing with, pardon me? Yes, at the University of Southern California, Dr. Ruth Zemke, who also then took a big initiative in Japan to develop occupational science. So it's parallel, but I've been saying, and Sharon and I were talking about it, that I see occupational science being the sociology to occupational therapy. In other words, the place where we can explore what the occupation side of it is all about. But that doesn't mean that it's a therapy in itself. It's not meant to be a practice. And there are still questions for research about occupational therapy as a profession. So, yeah. How are we doing?
There was a question about, you were going to say something about anti-colonialism?
Oh, yes.
Go for it.
Yes. I've, hmm?
Oh.
I think, yeah, the question was about anti-colonialism. Yes. So occupational therapy has had a lot of a white savior type of mentality, practice and experience in Canada, in Canadian occupational therapy. I cannot speak to other countries. And this in itself brings up a lot of questions and concerns and modern criticisms, rightly so, of occupational therapy. So I feel compelled to be thinking about that as I frame it. Unfortunately, it has not come up a lot, and that is partially how I've done the research and should be reflecting on that. Throughout my work, it's not as explicitly named, and I think it needs to be a separate pursuit, unfortunately. So I wanted to name it in that it is in my mind, especially as I'm thinking about feminist movement, I'm thinking about gendered forces and this kind of position of power and influence that we had as a profession where we're saying we don't necessarily have such a power and influence when we're considering racialized considerations. But yes, it's not coming up as explicitly as would be most impactful.
I do want to also say about the colonialism aspect is that it's been silent as a question until modern literature has a number of occupational therapists raising questions about the colonial nature of our practice and of the almost unstated dominance of white women. And we're an interesting case of white women workers coming in the 50s or after the World War, because we tended to be not the same white women who went into nursing to sort of save the soldiers, and not the white women who were getting into business and so forth, but often the wives, I guess, or partners of fairly middle-class, well-to-do families. And yet that aspect of, therefore, we didn't have to work, and you know, as Sharon and Katie have alluded, that most of the class of physical and occupational therapy went off into physiotherapy, easier to translate, and jobs were there, etc. Occupational therapists, you know, we stayed home with our families or we did other things. And so out of my class of 100, I think maybe 10 of us worked in occupational therapy. And at this point, there are probably about 2 or 3 that identify with occupational therapy. But I think the colonial question comes up because we really are silent and unconscious, you could say, of our colonialism. Yeah, that's enough. If you want to add something to it, please do.
Thank you. I think we're looking at the time, and we're gonna, if you have any additional questions for our guests, we'll be having a reception pretty soon, and they'll be open to meeting with you individually and answering any questions. But I think, you know, we've come from a interesting history, and hearing about history is so important because it also gives us indication of where we're going to be going. And just over the last, I'd say, 5 or 10 years, there's been such a growth and appreciation of what occupational therapists can provide in the healthcare system and also in the social system. So the sky is the limit for our profession, I think. All right, we'd just like to.
No, I think you can do the talking.
Good night.
I have my hands full.
Well, I found that, you know, I think looking at history is so important because it really, you have to know where you come from, or you could kind of look forward. And Katie and Liz, thank you very much for making the time for coming in and be with us and presenting at this lectureship. So on that note, we'd like to offer you.
Katie, our pleasure to have you, and Liz. Thank you so much.
Thank you so much. And I'd like to invite Corey Schmitz. Corey is our Associate Chair for the Department of Occupational Therapy, and I'm going to hand this to you.
Good, thank you very much. It's good to see the gifts being given over. Thank you. Just a few words, everyone, before we move on to the reception area. As Shanna said, I'm Corey Schmitz. I'm the Associate Chair and an Associate Teaching Professor here in the department. I want to just take a final moment to acknowledge all our special guests tonight, both Sharon herself as well as Dr. Liz Townsend and Katie. Thank you for being with us, Katie Lewis. That's good too. And they've asked me to talk just a little bit, Sharon, about your impact on my career and a meaningful memory for you to share. So we're going to end by celebrating Sharon a little bit here, which is good. And so I wanted to say that I have held you as a mentor since the beginning of my 14-year journey with my career in academia. And one of the things that jumps to mind as being a very specific thing that you have offered me has been related to student-facing supportive services. So you mentored me in a tremendous way related to crucial conversations and the way that we come into interaction with students in a way that sees them for who they are and the context that they have to navigate while they're going through their university education. So that's my professional one. And they also asked me to give a meaningful anecdote. I think I should advance the slide deck here. I'm going to find out though. Aha, there it is. So in 2017, I'm going to mention Indonesia again. I had the privilege of traveling as Sharon's companion and colleague on an experience in Indonesia that had us in the Surakarta area for about 3 weeks. And you really offered me some mentorship related to both program and curriculum development, which was very powerful. And we also had a really good time with my 10-year-old son, which was a lot of fun. We ate a lot of good food, and it was such a pleasure to see you with your colleagues in Indonesia and how they celebrated you too. Good. So I wanted to take this final moment to thank everyone who is in attendance, both through the Zoom internationally and nationally, everyone that's in the audience here in Edmonton, as well as in Calgary tonight. Thank you for that. And I also wanted to give a last special thank you to the donors, including ACOT, gratitude for their support, and also a recognition that it's the impact of the donors related to this lectureship that continue to influence our occupation and our occupation. Yes, sure you can. You are allowed.
I just want to thank all of my past colleagues and family and friends who came today to listen about occupational therapy. But remember, when you have your stroke, it's the OT that's going to teach you to eat, dress, and feed yourself. Oh, thank you.